So
yeah,
yeah,
okay.
let's get started. I would like to make some presentation before, and then so welcome to all the attendees to the guest speaker to this third sarcoma educational session in the framework of IMPERAS project. Thank you for joining us. Just for remark that the main goal of IMPERAS is to perform a prospective central review of all new sarcomas diagnosis in Spain in order to explore the agreement between pathologists. We encourage... yes, no problem, because she will be the first speaker. We encourage to all participants to submit questions or remarks by using the chat box. The question will be addressed right after each presentation to be more interactive the session. You may also ask to the presenter by using your microphone, but please just let me know by using the chat and you will be invited to ask the question. Please mute your microphone during the presentation to avoid interruption. For prospect educational purpose, this session will be recorded just for you to know. So now it's my pleasure to introduce our first guest speaker for today's. This is Professor Eva Warderman from Münster, Germany. She is chair and professor for Gerard Dolban Institute of Pathology. Sorry, Eva, if I didn't pronounce well this at University Hospital of Münster. She is very well recognized expert in soft tissue pathology and also have many contributed to many papers on this area. So I'm pretty sure we will enjoy the presentation. So Eva, please, could you start your presentation?
Yeah, thank you very much, Isidro. And first of all, I would like to thank you that you invited me, because it's a pleasure always to talk, especially with international people and pathologists, about tumors from the soft tissue and bone. So I hope you can see my screen already.
Yes.
Yeah. And for those who know that protein, they of course already know about what I want to talk. So I didn't put the name below so that you can see what it is, which protein, but we will come to this later. I thought it would be the best just first of all to present you some H&E slides, and then if you want, you can already guess what you think, what this could be, and you can also give me advice which immunohistochemistry I should perform to come to the correct diagnosis.
Okay.
So let's start first of all with some macroscopic information. As you can see, I was very lucky that the colleague who sent me that case, Thomas Rüdiger from Karlsruhe, he sent me also such a nice slide, a whole mount slide, which we normally ourselves do not perform. So you can see it's a huge tumor being somewhere solid and cystic, and there's here the gastric mucosa upon, and altogether, this tumor was measuring more than 15 centimeters in diameter, but 11 centimeters of this was a large cyst and the rest was more solid. The patient is female and 39 years old. And so I would say from my perspective, rather young. And if we now go nearer, then we can see that here's again the mucosa, and we see such a spindle cell proliferation, sometimes separated by these fibrous septae. And it looks rather monomorphic, so not pleomorphic. And if we go nearer, then you can see that these cells might remember a little bit of pericytes or fibroblasts or something myofibroblastic, but it's not very spectacular. Sometimes these cells are arranged in a more loose pattern, having a myxoid matrix. And there's my presentation gone away. Can you still see it?
No.
Okay, good, because suddenly it disappeared on my screen.
Yeah.
Here we are again.
Yeah.
Okay.
Okay.
And again here in very low cellularity, looking very.
Please, Eva, I cannot see your screen.
Cannot see?
No.
Oh, great. Then I will try to
yes.
give it you once more, because sometimes I don't know why these. Okay, can you see it again now?
Yes. Okay.
Okay, great. So moving forward, another area here, you can have the impression it could be something vascular neoplasia, and the tumor has, am I still there?
Yes.
Okay. And we have some true tumor necrosis, which is of course not such a good sign. And we've got these hemorrhages. Okay, so now let's move on with the question, what is your diagnosis? Have you already an idea? If yes, you can just chat it. I will open my chat again because it closed itself. I don't see any chat idea, but you could put something in if you want. And of course, the other question is important: which immunohistochemistry to use? So,
30 CD34.
Yeah, always a good idea, I think. And any other ideas? So you probably think of a GIST, for example, which of course can always be the matter, especially if it's such a ball-like polypoid lesion in the wall of the stomach and the mucosa is intact. Absolutely correct. I think we just move on a little bit and look what I have. I didn't bring you all my immunohistochemistry, otherwise I could do the whole afternoon, but we don't want that. So I just picked some of the stainings. And here's again a description of the histomorphology. And for immunohistochemistry, we see some two markers which are not very specific for anything. I just mentioned them because they were nearly the only ones to be positive. And this is CD10 and CD56, which is, well, more or less not so helpful, but at least it is something. I will show you the pictures in a minute. And interestingly, 20% of tumor cells show very distinct expression of cytokeratins, of MF116 EMA. And this looks very bizarre. All other markers, for example, for GIST or for a neurogenic tumor, which could also be, or smooth muscle differentiation, are negative. Ki67 very variable. We will have to see how it looks like. So this is CD10, not so helpful. And now let's look at MNF116. And you can see that suddenly, without seeing it already on the H&E, we've got a biphasic pattern. We've got these very monomorphic fibroblastic cells on one hand, and then these trabecular cytokeratin positive cells on the others, and they are intermixed. And to look for some other markers, CD56, S100 is negative, a very bizarre vessel pattern, and then this, in some areas, hotspot areas with a very high Ki67, in other areas there was only 1% or even less. So at that point, we are sitting there and have to think, what could it be? And oh yeah, there are now some chats, very good. So you thought it might be a GIST, okay, very good idea, but it's not. The cytokeratin expression in such a biphasic pattern would be very surprising. We have sometimes cytokeratin in GIST, although, so it's not excluding a GIST. But as you've seen, there was no DOC now, CD117. S100 was also negative. So let me move on to make it not too long. What we made, and what we always do in these monomorphic tumors where we don't know what it is, we do RNA sequencing. And this is what we do. I have to admit that this picture is not from this tumor. I borrowed it from Mr. Spence, who showed that diffusion for a plexiform fibromyxoma. This brings me later on to this entity, but for our tumor, in fact, the biphasic pattern, the partially cystic appearance, the monomorphic appearance, and the detection of a MEL8-1 Gli1 fusion is proving the diagnosis of a gastroblastoma. So, and this, I just want to show you this specific entity and also some others because they are not yet in the WHO classification, but they here and then come across my way, at least might cross your way. So just to make that short story a little bit longer, Metin described these cases 2009 with 3 cases and designated also this designation of gastroblastoma. And in fact, these are young adults. The tumors are located in the stomach. They have this biphasic growth pattern, can be very huge, express CD56. In fact, are negative for GIST markers, have this fusion, and they can metastasize. So, and we've seen this is at least locally high proliferative lesion. So it's important to recognize, one major differential diagnosis because of this biphasic appearance and this focal cytokeratin expression is of course synovial sarcoma, which of course can also be easily distinguished if you do just a FISH for a SYT, for SYT, for example, translocation, or immunohistochemistry for TLE1. To explain that these this GLI or GLI1 translocated or altered tumors are a big family, I want just to show you some other examples of tumors which we also see here, especially in the GI tract, having very similar alterations. These are two descriptions from other groups, one in a child, the other one again describing a series of these MELAT1, GLI1 fusion genes. And here is now our protein from the title page. And you can see it's a big family, and they all have some alteration in GLI. It might be either fusion or amplification or even mutation. So one example that you should know is gastric plexiform fibromyxoma, having the identical molecular findings as gastroblastoma, but looking completely different. Because in these cases, you've got, again, often in the stomach wall, these myxoid nodular proliferations, and surrounded musculature is hypoplastic. And this gives the whole lesion a plexiform appearance. And again, we've got these nice markers such as CD10, very helpful, and smooth muscle actin, but nothing else. So you just have to recognize them because of their morphology. And again, they have this fusion. Then we've got the Pericytoma, which is the first description of this specific group, which was done already in 2004. And the people then recognized that these monomorphic cells look a little bit like pericytes. And they have a specific translocation involving, again, GLI1, but also ACDB1, which is the actin gene. And again, young females and a monomorphic tumor. And finally, there is from Antonescu a description 3 years ago, again, about the identical GLI1 MALAT1 fusions as in gastroblastomas, but these tumors behave malignant. They have an epithelioid phenotype, and they express S100 and SOX10, which we didn't find in the gastroblastoma. And they are negative for cytokeratins. So obviously we've got a big family, all fused together by this GLI1 alterations, and it's important to recognize them. This has been last year description of these tumors in the head and neck region, and these have either GLI1 fusions or amplifications. I think there has to be done a little bit more work to recognize how near they are connected to the others. It's important to know that GLI1 is located on chromosome 12, where are also MDM2 and CDK4. So also in our D-diff lipose, for example, GLI1 is often co-amplified. So it not only a GLI1 amplification already explains the whole tumor and says this is belonging to the GLI family, but you should be aware that this can happen more than often than we expect. So the take-home message, my last slide, is that these GLI1 altered tumors can occur in different locations, not only the stomach, with varying biology and morphology. The fusion partners are these three here. We've got GLI amplification as another pathogenic mechanism for GLI activation. And finally, I think, and probably you too, that RNA sequencing is indispensable in soft tissue pathology, because we get more and more new translocations that we don't know, that we never saw before, and that we have to characterize. So that's all from me.
Vielen Dank.
You're welcome.
Eva, I have a question. So this type of tumor that have already described in gastrointestinal tract that looks like glomangioma or glomic tumor, with neuroendocrine differentiation. Do you think that maybe those tumors may belong to this GLI1 family of tumor?
Well, the glomangiomas and the glomus tumors also, they're a separate family with a different genetic background. So, and they often express smooth muscle actin, which we don't see in these tumors. So, so my suggestion is that these are different tumors. They are not connected. Well, they look very similar because they've also this monomorphic aspect and so on, but they are in fact different tumors.
Yeah. Did you test STAT6 in this case?
Yeah, we did, and it was negative.
Okay.
And there was also no CD34, although of course also solitary fibrous tumors can lose CD34. So it's good that you mentioned that, because in fact, more and more and more I use STAT6 in every life situation, I would say, because now I've seen already, as you will present probably, such as DDIF, or as you presented, dedifferentiated SFTs, they lose everything that you are used to, morphology, CD34, and they just express STAT6 and they have the translocation. So yeah, it's a good advice to do that always. But in this case, it was negative.
Okay, thank you. Let's check in if there is something to ask you about the check. Yes, Empire, something neural. Oh yes, that is a suggestion. Okay. So, do you think that some previous yeast? So, because there is not, there is some wild type. I know I am not an expert in yeast, but I know that there is some yeast wild type, some that may express CD34, and some GLI1 tumor may also reveal 34 expression, but that is rare. So from this yeast wild type, we should indicate any immunohistochemistry, any additional immunohistochemistry to excluding some of this family of tumor?
Yeah, you're absolutely right. I think I just saw, I think a week ago, one real wild type gist, one very, very, very rare, because normally if you do all what you can do, for example, not only PDGF receptor alpha on KIT, but also BRAF and what else you can do on GIST, and you also do RNA sequencing, then normally you find always something. And it might, of course, happen that you find such a tumor as this one, as a gastroblastoma, because they have a translocation that you didn't expect, of course, but you found it. In fact, those just having nothing are really, really rare. And I would say that although we have, I think, nearly 200 just not showing any mutation, I didn't check them all by RNA sequencing yet. So I think in those tumors, there might be some hidden cases like this one. There are also some probably epigenetically driven GIST or so that we don't recognize yet.
Okay.
But it's really, really, really rare. And normally I'd never believe a wild type GIST.
Maybe this is an exclusion diagnosis. I don't know. So there is an equation in the chat box. I don't know if you can see.
Yeah, I can see. Yeah, there is this question. There are some similarities between gastroblastoma and GLI neoplasms. Do you think they can finally be the same entity? Well, entity is, of course, a difficult word. I would say they are the same family. They all have GLI alterations and they have different fusion partners, but often these fusion partners are driven or regulate the same pathways, such as sonic hedgehog or wind pathway or so. So the connection between these is that they always activate very comparable pathways, but as they can occur in different precursor cells, there might be some differences in morphology and in immune phenotype. But yes, I think gastroblastoma with the GLI-MALA translocation belongs to the GLI neoplasms. Yeah. Okay. And should get entry into the WHO. But I think we don't get a new WHO before the next 4 years or so. or 25 or so. I don't know. Let's see.
Could be a provisional entity until then.
Yeah, absolutely.
So please, anyone have any question to Eva? You may open your microphone and ask directly by the chat.
Yeah, there is something in the chat about S100 and SOX10, which is absolutely correct, because as we learned from the past, S100 alone is not always the whole truth. So if you really want to have a new differentiation, I would always do both, because I have more and more cases they're having S100, but no SOX10. So they're not neural, they're something else. So it's important to do both, yeah.
Okay, thank you. Thank you very much, Eva, for your nice presentation. So if anybody have any additional remark or question, we may continue with Uta. So Dr. Uta Fluke from Department of Pathology of Radboud University Medical Center, Nijmegen, the Netherlands. She has also special interest in soft tissue sarcoma and have many papers of sarcoma diagnosis and research. Dank uns her. Vielen Dank for to be here. And if you wouldn't mind to share your screen, and please start your presentation.
Buenos días. Gracias.
Gracias.
Can you see it?
Yes.
Perfect.
Yeah.
Thank you for inviting me. I would like to present a case of 72-year-old male, and he was known with morbus Ollier or Ollier's disease. And as you can see, he has in his lower arm a pedunculated skin lesion. And furthermore, you can see the hand is malformed. And this lesion was excised. And you can see again the polypoid surface and below cellular proliferation. And here's a higher magnification with the epidermis, and you see slit-like vessels. And in the deeper soft tissue, you see infiltration of the cells. And if you go higher, then you can appreciate that the spindle cells have relatively monomorphous nuclei with which are normochromatic. So there are no mitotic figures. And here's a more sclerotic area with more well-formed vessels. And here you see around a larger vessel infiltration of the tumor cells. And sometimes you can see there's more solid aspect. This is the immunochemistry. CD31 was positive in the endothelial cells. And furthermore, you see in the SMA reaction kind of stromal cells which are reactive. But if you see in between the vessels, there's not really surrounding of pericytes. So this can be confusing. The diagnosis was made of a Spinoza Hemangioma. And when it was described firstly by Sharon Weiss and Franz Enzinger, they thought these lesions are low-grade malignant because some of the cases described in this paper are multifocal. The most lesions occur sporadically, and some of them can occur in together with Olier's disease or multiple enchondromas. And when you have the combination of Spinoza hemangiomas and enchondromas, you call it Maffucci syndrome. The age range is broad, and most people have a long history of lesions, and the first notion of lesions are often already in childhood. There are a variety of sites with most commonly involvement of the distal extremities, but also the trunk and the head and neck. The lesions arise mostly superficially in skin and subcutis, and the half of the patients have multiple lesions, at least if you follow the literature. Here you have a more classical pattern with also cavernous vessels and spindle cell component. The nuclei are mostly blunt looking, and in long-standing lesions you find thrombi, sometimes with calcifications. Here you see another example with more cavernous aspect and just few spindle cells in between. Another one which is more spongy with cavernous aspect and also slit-like vessels and a spindle cell component. And these lesions, so they get downgraded from spindle cell hemangioendothelioma to spindle cell hemangioma, but maybe we have to change the terminology again because these lesions have a somatic mosaic mutation in IDH1 or 2, and sometimes also in PIK3CA, which is a very typical mutation for vascular malformations. Sometimes you see mutations in both genes, and on the other hand, you can have vascular malformations which harbor IDH1 or 2 mutations without the spindle cell hemangioma pattern. And this is also the reason for the distribution that you can have multiple spindle cell hemangiomas, multiple lesions, which you also see back in the distribution of the enchondromas. There are also multiple. So therefore, the suggestion is that spindle cell hemangioma belongs to vascular malformations instead of tumors. These are the pathways. So IDH1 and 2 cause an imbalance of alpha ketoglutarate to hydroxyglutarate, and therefore you get an alterated epigenetic regulation and an alterated differentiation in tumorigenesis. And here the pattern how to get mosaic mutations, they will develop in utero, and it depends on the stage of development of the cells, how the distribution pattern, how many lesions you get. And if the alteration develops late, you can have a small area where you have the lesions, and if it develops early, the mutation, then you have a lot of lesions with large distribution, sometimes the whole half of the body. Yes, that's what it is. Thank you.
Thank you very much, Huda, for your presentation. I would like to ask you, So maybe in vascular spindle cell lesion, despite Canta or FOS, we may add also EDH immunohistochemistry for roll out this spindle cell hemangioma when we have doubts, or it may be helpful for us? Or what do you think?
I have no experience with immunohistochemistry of ADH 1 or 2 because mostly we do genetic analysis. Also in this case, so the patient was known with Olier's disease, and we found a mutation. So the lesion was long-standing, was not growing very fast, and you have no mitotic figures, you have no necrosis. So it's not a malignant lesion, and we know from malformations that you can miss pericytes. So the vessels are not always very well formed. It's a kind of mess. So yes.
Okay. Is there some question in the chat box? Can you see?
I have a question meanwhile while you're looking. Because, Uta, I was wondering, you mentioned this PIK3CA mutation. And I was wondering, are there any indications in these patients, for example, if they have so many lesions and they are growing, and also to treat them somehow? Because for the PIK3CA mutations, at least in some entities, you can use some MEK inhibitors or so. Do you know anything about that?
Yes, that's true. That's a good point, because vascular malformations are developed in the sense that they get treated with sirolimus. So, and they have very good results, and you can use them for vascular malformations, and most of them have a PIK3CA mutation. But it works also very well in tufted hemangioma and Kaposiform hemangioendothelioma. So there are a lot of vascular lesions which you can treat with sirolimus, indeed. Yes.
Regardless is benign or malignant.
Yeah, but also benign can behave malignant somehow.
Yes, and if you see, for example, Kaposiform hemangioendothelioma, it's actually not metastasizing, it's locally aggressive. And if kids die, they die from the Casabat-Merit syndrome and not really from the lesion. So if you can treat it, they get cured. Yes, it's a good point.
It's also the same that with the treatment with propanolol, no? With this lesion, with this vascular lesion that was treated also with propanolol, despite the malignancy.
Yeah, that's true. In children, they also do that. Big growing hemangiomas of the childhood.
Yes, that's the difference. If you want to use propanolol for benign vascular lesions, it's only helpful in hemangiomas. And if you have a vascular malformation, so it's a very different field, then they use sirolimus. Yes, that's the only possible treatment, actually.
And do you believe in WT1 immunohistochemistry as a discriminator between malformations and hemangiomas? Do you use that?
Yes, sometimes I use that. So we have got good results, but I also sometimes stain normal tissue with vascular channels, and then it's absent too. So it can be difficult. But if you don't have any other possibilities, it is at least a good addition.
Okay.
Yeah. But it's not 100% as everything.
Okay. Rita, welcome. Any question you may have or remarks in this case?
Problem in the lab. Yeah, I wanted to ask a question concerning the IDH1 or 2 genetic alterations. If you find, did you find in other vascular lesions, and if yes, what kind of lesion? How did you label them from a morphological point of view?
In few of other vascular malformations, we also found IDH1 or 2, but they were very few, and they were in combination with PIK3CA. So, and we just had biopsies. So the lesion was not excised totally, and I don't know whether we missed the spindle cell component. So I'm not sure for 100% whether these are separate lesions or in a spectrum of Spinoza Hemangioma.
I am asking this because I had a very strange vascular lesion, and I was very surprised because I had one of the mutations which are reported in the spindle cell hemangiomas, and macroscopically the lesion had the typical anatomical distribution of spindle cell hemangiomas. It was very similar, but histologically it was not in keeping with it. And I circulated the lesion, and different pathologists gave different diagnoses. And in the end, I reported as unclassifiable lesion with the IDH1 mutation, but I don't know.
Okay. Any further question? No? So we may go ahead with Rita. So it's not, it's not my pleasure to present Rita Laggio from Italy. She is an international expert in pediatric pathology and also in soft tissue pathology, and she has contributed to many papers on this area. So Rita, it's a pleasure for us to be here with you. So can you share your screen if you don't mind and start the presentation?
Do you see my screen?
Yes, and the next slide also.
Ah, okay. So I have to just a moment because I have two screens, and every time it's complicated to see which one is. Now?
The same.
No, but you can change it up there if you take the impostazione di visualizzazione button.
Okay.
And then you can invert it.
Okay?
Yes.
Okay. Okay.
Thank you. Thank you.
My Spanish is not the best, I have to.
No,
but that is.
Thank you. So this is a very unusual case we had 1 year ago. It is a 14-year-old girl with an unremarkable personal and family history at that time. And she presented at emergency room with abdominal pain, and she had also ascites, and CT scan demonstrated an heterogeneous mass with multiple peritoneal nodules. Ovaries were not involved by neoplasm, and there were multiple abdominal lymphadenopathies. So a suspicion of lymphoproliferative disease was given, and a biopsy was done. And this is all the material we had, and I'm going to show you these two areas. This is one of the areas, and you can see that there are these sheets of eosinophilic plant cells showing eccentric nuclei with abundant eosinophilic cytoplasm. And when we started looking at the slide, we thought it was part of the lesion, although there was also the idea they could be histiocytes or mesothelia. There were also other areas in which we could see these densely packed cells, very primitive and showing dense chromatin. At higher power, you can see that there are these typical neuroepithelial-like rosettes composed of these elongated cells with multilayered nuclei. The nuclei show finely dispersed chromatin. At higher power, we can see there are some areas of necrosis. We can see that some of these rosettes are centered by ardacers, and there were mitosis, and then there were also more densely packed areas in which there was no evidence of rosette formation, and you can see the cytologic atypia was prominent, and also mitosis were very frequent. There was no necrosis, and this is the immunohistochemical pattern. You can see that carretinine highlights the hyperplastic mesopithelial cells, and the remaining unstained areas are the tumor. And this is the cytokeratin AA1, AA3, which shows scattered isolated cells positive in the tumor part. And this is the tumor showing CD56 positive staining. Synaptophysin shows scattered positive cells. There was also SAL4 strongly and diffusely positive. CD99 was weak, and this is trimethyl histone, which was lost. So, any suggestion in terms of diagnosis and any hypothesis?
No idea. Somatic transformation in teratoma.
We were very concerned about this case. We did INI1, which was preserved, also SMARCA4 BRG, which was preserved, and then we came out with a descriptive diagnosis, malignant neuroectodermal tumor with features of embryonal tumor, similar to multilayered rosette, that is part of peripheral medulloepithelioma. And here you can see, just to compare the WHO, an image from WHO brain tumors showing medulloepithelioma, just to compare. So, embryonal tumors with the multilayered rosettes are embryonal neoplasm of the central nervous system, and they can show these three different patterns, which are part of a differentiation spectrum, varying from the ETMR, embryonal tumor with abundant neuropil and two rosettes, which shows a biphasic architecture, and the ependymoblastom and medulloepithelioma. And in our opinion, our case had some features in keeping with the medulloepithelioma or with embryonal tumor. However, this is a brain tumor, and this brain tumor is characterized also by genetic alterations. In fact, 90% of cases are part of the subtype defined as C19MC altered, which shows this microRNA cluster on chromosome 19q13 alteration. A small subset of these tumors are Dicer mutated, about 5% of cases. And there are also additional alterations involved in the CTNNB1, CP53. And you can see that this is only 5% of these tumors show Dicer mutation, and these alterations are mutually exclusive. On the other hand, peripheral medulloepithelioma, ETMF, are also reported, and these tumors are very rare. From a review of literature, there are about 17 case reports, and 9 were in a recent series by Murdoch in American Journal of Surgical Pathology 2018, and the age range is wide, but most of cases occur in the young patients and may involve ovaries, pelvis, and also sacrococcygeal region. And the origin is related to a pre-existing teratoma, or in some cases there is no evidence of a teratoma, and an origin from a presacral remnant of neuroenteric canal is hypothesized. There are not many molecular studies in these cases. However, in this study by Murdoch, 5 cases of with diagnosis of medulloepithelioma investigated by fish didn't show alteration in C19 and C, and there are no cases investigated for Dicer. We investigated our case for by NGS to looking for Dicer1 mutations, also led by the evidence of loss of trimethyl histone and SALT4 expression, which is reported in especially in Dicer sarcomas. And we found it. This tumor was Dicer1 mutated neoplasm. In fact, there was a germline mutation and also a mutation in the hotspot in the tumor, as reported in Dicer tumors. And also, we found a mutation in CTNNB1. There were also other copy number variations. We performed at that time, just to confirm the hypothesis, we were dealing with one of Dicer-associated medulloepitheliomas, but located in a peripheral site. We performed LIN28, which is reported as strongly positive in this group of tumors, and you can see that it was actually very positive. So our final diagnosis was pelvic neuroepithelial tumor with the features of ATMR in Dicer1 syndrome. Dicer1 syndrome is associated to mutation of Dicer gene, which is involved in the process of maturation of microRNAs from precursor molecules through the cutting the pre-microRNA. And the syndrome is characterized by a variety of tumors, and tumors arise when a second hit somatic missense mutation arises in the most frequent hotspots so far reported, which are so far 3. And tumors are more frequent in children and young adults, and 5% of carriers show the neoplasm at the age less than 10 years. Here there is the list of all the neoplasms occurring in the context of this syndrome, and you can see that so far ATMR-like cerebellar tumors have been reported, but there are not peripheral medulloepitheliomas or ATMR-like tumors reported, although neuroectodermal differentiation is reported in other Dicer tumors. And this is an hypothesis. It is becoming more and more evident that Dicer-related tumors show a variety of morphological features, but especially there are appearances which resemble blastema or are included as teratoid neoplasms, or sometimes they show just the predominance of one lineage. Among those which show predominant blastomatous appearance are the pleuropulmonary blastoma. You can see here the lung lesion with these primitive mesenchymal cells lining cystic spaces. And these are sarcomas, which are more characterized by the evidence of one lineage and mesenchymal lineage, and are characterized by characteristic features combining pleomorphism, primitive cells, and also cartilage, and as reported in this large series from the review of literature by Warren, who reported 83 sarcomas. And intriguingly, there is this nice teratoid group, which is emerging in the literature, which includes rhabdomyosarcomas arising in pterygoid neoplasms, but also in some thyroid neoplasms, and also in the recently reported presacral sacrococcygeal teratoid tumors described recently by Nakano. And you can see here from the original paper the teratoid appearance of these tumors, which arose in the sacrococcygeal region and showed glandular differentiation, also some neuroectodermal areas, rhabdomyosarcomatous features, and cartilage. So probably our case is part of this spectrum and is characterized by the evidence of only the neuroectodermal component. And this is another case, just I'm showing a few slides to complete the picture, in which there is more evidence the teratoid appearance. You can see this gland-like structure. This is a 22-year boy, and the mass was in the paraspinal region, so very close to the sacrococcygeal region. In this case, there is also these nice gland-like structures in which you can see there is a inverted polarity with these vacuoles in the parabasal region resembling the primitive lung, apart from areas with rhabdomyosarcomatous differentiation. This is in a rhabdomyosarcomatous area, and this is myogenin and desmin, and you see alpha-fetoprotein positive staining in one of the gland-like structures, and this is in keeping with a primitive lung differentiation, which is known to be positive for alpha-fetoprotein. This tumor had been originally reported as rhabdomyosarcoma arising within a teratoma, and you can see also the SALL4 positive staining and loss of expression in some areas of trimethylhistone. In this case also showed a biallelic inactivation of DICER1 gene. So in conclusion, this is another, these two cases show how the morphological spectrum of Dicer sarcoma may be wide, how the expression of SALL4 combined to loss of trimethylhistone may be an interesting clue, and probably when we see strange lesions which resemble embryonal tumors or germ cell tumors, we have also to think about a Dicer.
Thank you, Rita. Very interesting, your case. I have two questions. So, because this tumor remind me the appearance of immature teratoma with some transformation or something like this. So when we see immature teratoma with other component, for instance, rhabdomyosarcoma component, should we think in the possibility of Dicer mutated tumor? This is my first question. And the second question is regarding beta-catenin. Did you test beta-catenin in this case? And do you think that beta-catenin positive or nuclear positivity beta-catenin would be helpful to suggest or suspect Dicer tumor?
Thank you for as far as it concerns beta-catenin, we didn't perform immunostaining because we have in our lab, it is not always it is not always very reliable in terms of association with the mutations. So we did, and we discovered the beta-catenin mutation after we had already done the diagnosis and we didn't perform. But yes, it's interesting, and it should be interesting to perform new staining. But the beta-catenin mutation is not constant in all; it's not always present, and probably and there are different types of mutation in different types of Dicer tumors. Also, for example, in the rhabdomyosarcoma, there was no beta-catenin mutation. While it was useful also methylation profiling, we didn't perform. I didn't show, but both cases were analyzed also for methylation profiling, and it is interesting that while the first case, the rhabdomyosarcoma, went in the group of brain Dicer sarcomas according to the Heidelberg classifier. The second case, our case, the medulloepithelioma, had clustered, although with a low score, with the medulloepitheliomas, with the DSMR family. As far as it concerns the teratomas and immature teratomas and differential diagnosis from Dicer, it is in our case we initially made a diagnosis of neuroectodermal neoplasm arising probably in the context of a previous teratoma, and we had only a biopsy, so we could not hypothesize if it was or not related to teratoma. But it was, and also SALT4 can be expressed even in all primitive cells. But loss of trimethylhistone was an alert for us, because we keep doing it in different tumors, and we have seen that when it is combined with SALT4, can be of some help in this as a potential diagnostic clue. For the second tumor, the one which was which was rhabdomyosarcoma, we suspected a Dicer since the diagnosis, and we went for NGS looking for Dicer because the site was unusual for a germ cell neoplasm, because it was a boy and it was paraspinal, and in area I didn't show just to be on time, but there was also an entrapped nerve trunk. And we included in the differential diagnosis also a triton tumor, but we could not explain why there was the positive staining for alpha-fetoprotein. Although the patient did not have rise levels in the blood of alpha, in the serum of alpha-fetoprotein, and in that case, the SALT4 staining together with trimethylhistone was a red light for us, and we investigated either one mutation, and it was positive for it. And then the father was, and then family was investigated, and they discovered that the father was the carrier of the mutation.
Okay, thank you. Can you see the chat? Because there is a question from and remark from Enrique de Alba.
No, I can just a moment.
You can. Fantastic case, Rita. Can you elaborate a bit on which are, in your opinion, the clues, clinical morphology, immunohistochemistry to suspect this diagnosis when you see an undifferentiated neoplasm and to indicate that sequencing confirming analysis? Thank you, Enrique de Álava.
So as far as concerns sarcomas, as I said before, there is the fantastic paper by Warren, which is very highlights the cytologic pleomorphism, and in the context of rhabdomyosarcoma-like appearance, myogenic differentiation, and also chondroid areas may be a good clue to the diagnosis. Also, generally, for rhabdomyosarcomas, those in special sites, like in cervical region, in the uterine cervical region, you have to investigate because that is a typical site for Dicer. But the immune, I rely a lot also on this combined pattern of SAL4 and trimethylhistone.
Okay, thank you. If you don't have any further question, we can go ahead with Dr. Thank you very much, Rita. Grazie mille. And our last speaker is Dr. Carlos Monteagudo. He is full professor of pathology department of the University of Valencia. He is a very well recognized dermatopathology expertise and has contributed also to many papers on this area. So, Carlo, please, Rita, can you stop to share? No, Carlo, please.
Thank you, Isidro, for inviting me to share this case with you, and I expect a lot from you too. This is a 44-year-old woman with systemic lupus erythematosus and antiphospholipid syndrome who developed subcutaneous and skeletal muscle nodules up to 30 millimeters that were consistent on CT with panniculitis, metastasis, or lymphoma. She also had bilateral breast nodules on mammography consistent with malignancy, and also numerous reddish cutaneous nodules progressively developed. These were the cutaneous and subcutaneous nodules. Can you see the slides correctly, Isidro?
Yeah.
Okay, thanks. You can see here on palpation the subcutaneous nodules and of course also the reddish multiple cutaneous nodules. But more importantly, this patient developed a massive multisystemic involvement in bones, liver, lung, spleen that were consistent on CT and PET with metastasis. She has no fever, but she has a thrombocytopenia which requires platelet transfusions every 2 days. You can see here the multiple lytic lesions. They were present in the pelvis, in the vertebral column, in the sacrum, in the femur. And we can also see here the subcutaneous and skeletal muscle nodules. These are the bilateral nodules in the lungs. In November 2020, there were few nodules in the liver, but if you see in May 2021, there were hundreds of nodules in the liver. You can see here, and in the spleen. And this is the situation of the patient currently at this time. Let's go to the histology. This was the first subcutaneous lesion chronologically developing in this patient. As you see, this is a multilobular tumor with highly cellular areas, or moderately or poorly cellular areas, with a lobular growth, also with dilated vascular spaces, some of them, few of them with thrombosis. This is the constant lobular growth pattern of this tumor and of these tumors, as you will see, with some of them with low cellularity, with flat endothelial cells. This is what Juan Rosay called the capillary lobule on the left. And also there were areas with moderate cellularity that you can see here at higher power. In these areas, the pericytic cells are numerous surrounding the endothelium, which at this here is more cuboidal. But there were also highly cellular areas with small vessel lumina. Ki67 immunostaining is high in the cellular areas, as you see, and smooth muscle actin immunostaining is surrounding the endothelial cells all over the lesion and all over whole lesions. There were some foci of extramedullary hematopoiesis which were highlighted with glycophorin A, as you see. These are the breast lesions. As you see, these lesions have a lobular or diffuse growth pattern. Some of the vessels were interconnected and cellularity is variable. And again, the Ki67 immunostaining is high in the most cellular areas, but the smooth muscle actin immunostaining is constantly present surrounding the endothelium. And the cutaneous lesions look similar, lobulated growth pattern with feeder vessels and capillary branches and the smooth muscle actin surrounding endothelial cells. So, you know the clinical and the histologic findings. So the first question is, at this point, what's your first diagnostic approach? Is this benign? Is this malignant? Is this reactive? Or I don't know. I cannot see the answers, but no.
You may answer by the chat.
Well, I thought I would receive some answer from the audience, but D, B, DBC.
Very heterogeneous lesion.
No ways, just DBC. This is important. You will see, this is very important. So we can continue if you want. It's okay. So the next question is, what's your tentative diagnosis? Bacillary angiomatosis, well-differentiated angiosarcoma with metastatic dissemination, Kaposi sarcoma, reactive angioendotheliomatosis, extravasculars, of course, disseminated lobular capillary hemangioma, or none of them. Well-differentiated angiosarcoma, Kaposi sarcoma, bacillary angiomatosis. Okay. Okay. I can help. This is the Warfin study staining, and we can see that there were no bacilli, as there were no neutrophils and no granular, dirty, necrotic material. So let's go to the differential diagnosis. Some of these, you have selected some of these. Bacillary angiomatosis first. This was, of course, this was clinically suspected, but not histologically, as I have shown. But again, the clinicians believe, and I understand, absolutely understand that this was the correct diagnosis. but this was abandoned because of negative PCR and serology, but more importantly, because there was no response to treatment for 2 months with 2 antibiotics. Even the lesions dramatically increased in number during the treatment. Angiosarcoma, well differentiated, was disregarded because of the lobular growth, the constant presence of the smooth muscle-actin pericytic layer, and no endothelial atypia. Kaposi sarcoma was eliminated because no HHV8 immunostaining was present, or hyaline globules, or slit-like vessel formation. What about reactive and endotheliomatosis? Well, it has been associated with antiphospholipid syndrome, and this was our first diagnosis. But Chris Fletcher, in the large series, stated that reactive endotheliomatosis tend to have solely cutaneous involvement. So this is a problem. This opinion was also shared by Franco Rongioletti, who said that the vascular proliferation affects no other organ than skin. So we don't know. This was our first diagnosis, but not clear. What about disseminated lobular capillary hemangioma? Well, this is how it looks like. We can have acquired multiple disseminated lobular capillary hemangiomas, or they can be congenital, but the clinical appearance is similar to that the lesions in our case. It can be caused by mechanical trauma, burns, drugs, neoplasias, malformations, but also by or associated with antiphospholipid syndrome. In fact, this is a paper on this association. Interestingly, more than 10% of the cases had extramedullary hematopoiesis, as in our case. And someone in the audience can remember when he saw first time. Well, there are different variants, clinical variants of biogenic granulomas. It can be solitary, can be multiple, and in that case, it can be localized, disseminated with satellite lesions, can be subcutaneous, intravenous, congenital, can affect the mucosa of the gastrointestinal tract or the upper airway. But until 6 months ago, there was no report in the literature of cases like this. And in November 2020, these authors reported 8 cases of what they call congenital disseminated biogenic granuloma as an aggressive multisystemic disorder. The clinical appearance of the cutaneous and subcutaneous lesions, as well as the histology and the visceral involvement, you see, in these cases, there were lesions in the liver, the spleen, bones, lung. So it's completely similar, very similar to our case. But these were congenital cases. There is no report in the literature of an adult patient with these lesions, to my knowledge. So the diagnosis is multisystemic, current diagnosis is multisystemic disseminated lobular capillary hemangioma, which was associated with antiphospholipid syndrome, and we don't know if this is really important. Lobular capillary hemangiomas have BRAF or NRAS mutations, in contrast to reactive endotheliomatosis or bacillary angiomatosis. And these mutations upregulate MAP kinase signaling, which leads at the end to aberrant angiogenesis and lymphangiogenesis. The authors of this paper, of the November 2020 paper, did not perform any genetic studies. But we did. We studied 3 lesions by NGS. The first subcutaneous lesions that chronologically appeared or developed in the patient had an NRAS mutation, a pathogenic NRAS mutation, which is well known, is present in some malignant tumors like melanomas. The second subcutaneous lesion that we studied had a MEK1 mutation, a MEK1 somatic mutation with a allele frequency of 17%. And interestingly, and it was performed separately in different times, one breast lesion, the only breast lesion that we have studied, had the same MEC1 mutation, a somatic mutation with an allele frequency of 27%. This MEC1 mutation have not been reported, but the prediction is that it can be pathogenic. So these three mutations act through the MAP kinase pathway and may facilitate cellular proliferation of endothelial cells and pericytes. And most importantly, this can be the target of MEC inhibitors, and we have many of them, like trametinib. And I say that because the patient is currently treated with sirolimus and pathopanib. You were talking about sirolimus previously. It is very useful, not only as an immunosuppressor, but as some people in the panels stated, is also useful for malformations, vascular malformations. And pathopanib is anti-angiogenic. But importantly, also the multisystemic involvement, the visceral involvement remains, as I showed you in the patient today. Yesterday, to be honest, yesterday was the last time I talked to the clinician. And the platelet transfusions are needed every 2 days. So this is our diagnosis at this time: aggressive multisystemic disseminated lobular capillary hemangioma. If you have seen any case like this one, please share with us your experience. And if not possible today, please contact me. I insist, because this is not only for academic knowledge. This is because the patient is a young patient, is a problem for all of us in our hospital. Thank you.
Very nice case, Carlos. Thank you very much. So this case looks like, I don't know, I wonder the Casabas-Merritt syndrome in this case, because with this many vascular lesion and the thrombocytopenia, this is complex for the follow-up of this patient.
This could be considered a Casabas-Merritt syndrome.
Chronic, I mean.
Yeah, but the problem is that since the patient also has antiphospholipid antibodies, autoimmune disease, and we suspect that she's also producing antibodies, antiplatelet antibodies at this time. So it's more complex, but of course, she has so many hundreds of lesions all over the body that the possibility that the platelets are kidnapped is absolutely correct.
Yeah, this is another lesion of soft tissue. This is disseminated endotheliomatosis that I have already described it with P10 and P1K3K mutation that looks like in some way similar to this case, that this is disseminated endotheliomatosis. But I don't know how is the differential diagnosis between your diagnosis and
well, there are entities like the multifocal lymphangiomatosis with thrombocytopenia that theoretically could enter perfectly in this case, but these are lesions in the newborns and children under 6 months of age. But more importantly, the histology is that of proliferation of lymphatic vessels, lymphatic slits, sometimes spindle cell proliferation, which are podoplanin D240 positive. In our case, the endothelial cells were negative for podoplanin, but morphologically, of course, it's not possible to make this diagnosis. But interestingly, the Kaposi-4 lymphangiomatosis, which is also similar or in some way, is also associated with RAS mutations. So, I mean, there is something here. And more importantly, some of these entities, which are not useful for us in our case, but the treatment is similar, and sirolimus is effective, but also we have just, I think that there was just one paper telling us that the trametinib has been useful also in, I think I remember, in caposiform lymphangiomatosis. So next step, if the clinicians wants, is to try the trametinib in this patient, because the risk of death is really high, really high.
Rita? Mm-hmm.
I had a case like this, but in a child, and the patient showed one, then a second, then more pyogenic granuloma. Lesions looking like pyogenic granulomas. We were surprised because of the young age and the multiple lesions shown, but the patient did not have any consumption coagulopathy.
I didn't hear if there were visceral involvement.
Yes.
Which organs were affected?
I think, if I remember, I don't remember if it was liver. I'm not sure, but I got just a few months ago, and I remember it was very strange because I didn't expect a pyogenic granuloma in a visceral organ.
I know that there are some reports with just one lesion in the trachea, bronchial mucosa, in the gastrointestinal tract, several, but in the mucosa, not in liver parenchyma. There is only one report of one lesion, solitary lesion. I think first, we have to think in the patient, and any experience. Do you remember the treatment of this case, which was effective?
No, I don't remember because actually I didn't give the diagnosis in the start because I was surprised of the morphology of pyogenic granuloma, and then we discussed with our dermatologist, and they gave the hypothesis of this entity, and then we studied, and we did. Now there is ongoing molecular characterization with NGS, by NGS.
I would very much appreciate if you could send me by mail more information, because at the end, the experience of others is very interesting, but also at the end we have to communicate this situation to avoid the death of a patient, because this process is very aggressive.
Yeah.
Okay. Any further question? Eva, Professor Jombar, Uta,
No questions, but I'm very impressed. I have to say, I haven't seen such an extensive case with so many lesions, and it's really helpful. Thank you very much again.
Thank you.
Any question for the attendees?
What age was do you know at what age the patient started to have lesions?
There was no, at the time of the lesions started developing, there was no a high level of antiphospholipid antibodies. So the patient has, for years, antiphospholipid syndrome, but at this time there was no important clinical situation. It was a surprise, and we believe that this is because the hypoxia produced by the thrombosis, which could be present in different areas of the body. But the explanation is difficult. There is no drug which could explain these lesions, and the only thing is the hypoxia because of the thrombosis due to the antiphospholipid antibody syndrome. I cannot answer because we don't have the answer. We would like to know.
Great case.
Any further question? Any? So if you don't have any further question, I would like to thank to all the speakers. That was a great case. I'm pretty sure we enjoyed all this case. And hopefully we may see you in next session. So if you want to join us in next session, I may send you the link. And probably in the near future, we may plan in an additional session with you. That is all. We are running on time. Thus, thank you very much for your participation and see you in the next session. Bye-bye. Vielen Dank.
Thank
Gracias
you.
mille.
Bye-bye. Adios.
Thank you.
Gracias.